section about bisphosphonates if you don't have that particular book, or you don't if you've got the online version. The question was, can I just look it up in the drug book? Yes, you can, but I'm going to tell you, there is no way in God's green earth that you're going to be able to remember everything about every drug, and if you do, it will drive you crazy. Learn these drugs by classification, okay? Because they come out with 300 to 400 new drugs every year. And I look at it and I say, oh, well, that's an ACE inhibitor. I know what the side effects of ACE inhibitors are. So I don't need to look up this particular drug and learn every little thing about it. Learn them by classifications. If you don't, you're going to drive yourself crazy. Look at the bisphosphonates that I talked about. Look at the insects that I talked about. Okay, so those are things that you might want to think about whenever you're studying pharmacology. Learn them by class. Don't try to learn individual drugs. All right, so patient teaching. What we want to do is, if you look at this, what is this? This is just ergonomics. We want to keep that body as functional and as neutral position as possible with proper posture, body alignment. Identify activities that take a long time to do or things that you need assistance with. Don't have your patient not be afraid to ask for help. Pushing or pulling or sliding heavy objects rather than pulling them or picking them up is probably a better thing. Okay? Now, surgical management. Typically what you're going to see is that surgical management of OA is done for people that don't do well with conservative treatment, or despite conservative treatment, they still can have pain and disability. Treatment of choice for OA of the hip or knee is an arthroplasty or replacement. The primary indication for total joint replacement is intractable pain that disrupts sleep and daily activities. That's why I finally decided to have my replacement done, is that I couldn't sleep at night because there was no home position. So, joint arthroplasty. Partial joints, you might see a reshaping of the bones. You might want to see that they will put in like a partial. They may only put in this portion if the capsule is sufficient. Or they may do a total where they replace the ball and the cup so that it works very well. Total hips, total knees probably are going to be the surgeries that you're going to see most often. And those are what you see on joint camp and on post-surge too, quite a bit. Total shoulders or total elbows do occur, but often not as in the highest numbers that we see. Probably total hip or total knee are the orthopedic surgeries that you're going to see the most. Now, I love this cartoon. It says, well, do you think more like Beyonce or more like Heidi Klum? I can't decide. It says, Mom, that's not how hip replacement works. So, total hip arthroplasty. What you see is that porous socket that's mounted in the acetabulum, and then this shaft is mounted into the femur. This is what this portion looks like. Okay? And you can see this one has only the 1 or 2 holes, but this one has holes all the way down. And that is to provide for bony growth through to allow that to become more and more stable. Now, what you're going to see is there are 3 approaches. You see a posterior approach, you see a anterior approach, Most of the time, anterior or posterior, there's a midline approach that they do for minis, but you often see these two done most often. Posterior approach is the traditional surgical procedure. It's an 8-inch. Mine is actually 12 inches. I measured. It's a longitudinal incision or an anterior ladder. You will see much more muscle damage. You will see less chance of dislocation. It's typically done for people of size, and it's typically done whenever there is a revision of the replacement. Okay, posterior is the traditional. We are starting to see a lot more anterior approaches. These are people, again, their first hip replacement. You see a shorter hospital stay, quicker recovery, there's decreased soft tissue damage. But again, it has to be for people of moderate to normal body size. This is what you find with those two. Anterior is much forward. Posterior, again, it is basically on the side of the hip. If you've not seen an orthopedic surgery table, this is what it looks like whenever they set them up to do a hip replacement. Okay? This would be for that anterior approach. And yes, it does look like the medieval torture chain. Surgical approaches, anterior here, posterior here, lateral is here. Now, one of the things that I will tell you is that if people are having hip pain, basically groin pain is at that joint. If they're having hip pain over here, that's the bursa. Okay, you can get bursitis of your hip just like you can of your elbow. But true hip joint pain is in the groin area. Okay? Basically, they would do the replacement, and then often what you will see after surgery is the on-cue pump. Do they use those at Rowan? Okay. These are the coolest things I would tell them. You know, where a lot of times what we would do with patients is use PCA or patient-controlled analgesia. Okay? Basically, instead of hitting the button to deliver pain medication post-surgery, what this does is this catheter goes into your surgical site. And there are 3 days worth of medication in this little bowl. And it delivers a constant supply of drug to your surgical incision. Okay? And then after 3 days or so, they take it out and you're good to go. With this pump, I took 2 Tylenol, Percocet, my entire hospital stay, because I had no pain after surgery. Okay? But this on-cue pump, basically 3 days supply of medicine directly into that surgical site. And it worked like a charm. Yes?
I had that for my ankle surgery. My ankle is hurt out either.
Yeah. Much, much better for pain control than having to remember PCA. And I mean, that physical therapy got me up the first night of surgery. I mean, I came back to my room at 2 o'clock, they would get me out of bed at 6 o'clock. And I had no pain. Now, hip precautions.
Aww.
But,
With my dad's condition, they went through the front and actually separated. They don't cut the muscle.
No, they don't
anymore.
cut the muscles
They
at
separate
all.
and stretch them.
Oh, wow.
Is that relatively new? Or?
That's probably within the last 5 years.
Wow.
That's that anterior approach. Okay?
So if they do posterior, they just do that and you cut.
They cut. Oh yeah, he cuts. And I've got scars prove it. It goes from like here down to here.
Because I know his is really only like.
Yeah, it's only about 4 to 6 inches. But they do it this way. And like I said, if you've not had a hip replacement before, and if you're of normal body frame, they prefer to do the anterior approach because post-operatively you have less complications.
He was up walking that way.
Yeah. The only problem with the anterior approach is that there is a higher risk of dislocation than the posterior approach.
Because of all the muscles getting
Just because of the muscles being pulled
the
around.
bruise was
Oh, it's a significant bruise. Yeah. Both approaches do not stand or sit for prolonged periods. Ambulatory aids when walking, and that may be a walker to start off with and a cane later on. Basically, you're going to use assistive devices for ADLs. You don't want to bend at the waist. You don't want to twist the body. Typically, the precaution is 90 degrees, meaning sitting straight up is not the thing that you do. You don't lean forward. Basically, you're going to stay in a slightly reclining position, and that includes on the toilet.
And is this just until they're healed, or is this from here on?
This is from 6 months. Okay? Don't allow your legs to cross. Use a pillow between your legs to keep your legs from going toward that midline. With interior approaches, like his dad, they should not step backwards with the surgical leg. In other words, you know, when you're in the grocery store or Target and you're in those little narrow lanes and you're pushing your buggy this way and someone's coming this way, you have to say, I'm sorry, I can't back up, because you can't take a step back with that leg because it can cause dislocation. Okay? You always have to go forward. You can't go back. And that usually is for the 6-month period. Do not allow that surgical leg to turn outward. With your anterior approaches, they sleep on their surgical side or on their back. Posterior approaches, they can't bend their hip more than 90 degrees. In other words, they can come up this way, but they can't get it all the way straight. Okay? Both from the bottom and from the top. They don't want to turn their leg outward, and typically your people with this posterior approach need to learn to sleep on their back. I've always been a side sleeper. And so that was one of the things that was most difficult for me. So one of the things I had to do was get a bed wedge so that I wouldn't turn over. Because I couldn't turn over because I set it and had pillows on either side so I wouldn't turn. But sleeping on their back is
But it's
the
only
best
for
way.
6 months, right?
For
All of
6
those.
months. Yes. Okay, like for example, I don't want my hip, the angle of my hip, if I bring my leg up, if it's straight out, I can't do it on this hip. But if I bring it up, this is a 90-degree angle. I can't bring it up, knee to chest. I can't do that. Basically, if I'm sitting, I have to sit slightly back because I don't want to be 90 or more than 90. You know how you sit on the toilet when you read like this? No, can't do that. Or standing or sitting, you can't break that 90-degree plane. Okay? That hip has to stay in that neutral position. We'll go more over these whenever we do the sim. Some of the complications are going to be dislocation. How am I going to be able to tell if that hip's dislocated? Shorter and externally rotated. Just like it does whenever you have someone with a hip fracture. Okay, infection is going to be an issue. One of the things that you will see, and you probably saw it the day that you went for your OR rotation, nobody got in to see the hips, right? Infection control. They basically will limit the amount of people in the OR. I used to work with a physician that before he would scrub, he personally took every person that was going to be in his OR's temperature. And if it was slightly above where he thought, nope, get a substitute, you can't be in my OR today. So infection control is going to be one of the things that you're going to see. Again, because of the risk of osteomyelitis. Some of the surgeons I've worked with have done like the full-on Ebola suit. I mean, with the head gear and the whole 9 yards for their surgeries. And everyone wears those in their OR.
When I watched Total Knee Replacement, the PA and the surgeons, they all had those, it was like completely like.
It looked like a space suit.
Yeah.
They prefer to wear it instead of a fan, so it's cooler.
It's a whole lot cooler. But infection is one of the things that you're going to see. Typically, whenever you would have one of these patients to go down, they will pre-med them with antibiotics. Usually it's a ceftriaxone, like a cephalosporin or cefotaxime, okay? But the new American Association of Orthopedic Surgeons guidelines are, it can be either the cephalosporin or it can be vancomycin. And they will use vancomycin if that patient has a history of MRSA or the hospital has had recent outbreaks of MRSA. Typically they do it 1 to 2 hours if they're doing bank, 1 to 2 hours prior to surgical incision, and then they will continue it for 3 doses, usually about 24 hours. Okay? One thing I will tell you about bank, the reason it's done 1 to 2 hours is it takes almost 90 minutes to infuse it. If you infuse vancomycin too quickly, patients can have a reaction. It's called red man syndrome. Okay? You seen it? They feel like they're on fire because they get just flushed is not the word. They're super flushed. And it feels like their skin is on fire. So don't infuse it too quickly. Usually the ceftriaxone is given 1 hour before incision, and they continue for 24 hours afterwards. They don't put them on 7 days of prophylactic antibiotics because it's not been proved any more effective than just the coverage for 24 hours. VTE, well, definitely, anytime you have any surgery on the legs, whether it be knee or hip, it increases the risk for pulmonary embolus or DVT. One of the things that you will always see done with these folks is they will be covered with an anticoagulant, an injectable anticoagulant while they're in the hospital. Usually heparin, enoxaparin, or I can't remember what a Rixtra is. But a Rixtra is one that a lot of orthopedic surgeons like. But they will continue on those until discharge. At the time of discharge, they will be placed on either Coumadin and or one of the newer anticoagulant drugs, like Eliquis or Xarelto, any of the band, Apixaban or some of those drugs, for at least 4 to 6 weeks after. Okay? And then one of the things you're always going to have them do is continue to wear their TED stockings throughout their recovery. and you will have the physical therapist as well as the nursing staff, if you go home with home health, to do DVT checks. Okay? Typically, like I said, 4 to 6 weeks. There's a Relco. Of course, this has been 5 years ago. I have no clue how expensive it is. My copay was $120 for 90 days supply. So, 45 days. But anyway, anemia. Orthopedic surgery is bloody. So often what you may see is that sometimes they will pre-med several weeks out with something like Procrit, so that it will, or erythropoietin, to tune up their blood supply, especially if they're slightly anemic to begin with. A lot of times what you will see is these patients will require 1 to 2 units post-operatively be transfused. That will depend, of course, on what the H&H is. Okay? Basically, transfusion usually occurs if hemoglobin gets below at 6 or below. Now let me show you a little trick. With H&H, I can tell what my patient's fluid status is by looking at both of them. Say, for example, my hemoglobin. Oh, sorry. Hope no one has to go to seizures. Hemoglobin is, we'll just say 8. And my hit crit is 26. Okay, those are my actual numbers. Based on the rule of threes, okay, basically what you see is 3 times the hemoglobin should equal the crit. Okay? So let's do it. 3 times 8. That's an O. That's not plus. Is equal to what?
24.
Okay. So look at this number. It's higher than this, right?
Mm-hmm.
If it's high, they're dry. So this person is dehydrated. So now let's do it this way. Six is what? 18. This number is higher than this number, right? Still high, they're dry. This is higher than what it should be here. This person is dehydrated. Now let's do it this way. Times 14 is what?
Mm-hmm.
Okay. I'm expecting that my person should have a hematocrit of 42, but I've got 26. What that means is this number is lower than this number. If it's low, they're in overload. This person has fluid overload. If it's high, they're dry. If it's low, they're in overload. Quick and dirty way to look at someone's hydration status. As I said, if someone is at 6, they usually transfuse. Neurovascular compromise, we're going to look for patients that have, we're going to have and below that will be transfused. Okay, so total knees are the other type of surgery that we see quite a bit. Expected life of a knee implant is about 20 years. Sometimes they're done as a minimally invasive surgery. There can be no severe bone loss, no obesity, or no previous knee surgery. Advantage of this is less blood loss, less pain, more range of motion. Typically, they only do a partial knee with this. If they're doing a total knee, they do a much larger incision. Preoperative teaching, most of the time you need to talk to them about their assistive devices and their CPM, or continuous passive range of motion machine. These suckers are sort of the bane of a knee surgery patient's existence, but they're great for nurses because in order to keep from having to do continuous range of motion on this patient, we just pop them in this machine and it's set like with full extension, and you want to have a bend of 20 to 30 to start off with. What we hope is by the time that they get out of the hospital that they've got a 90-degree bend. Okay? They go home with this machine and continue that therapy. Now, one of the things that you will see is that a lot of patients with knee replacements can use a stationary bicycle as a good way to do physical therapy. Traditional surgery is done with an 8-inch incision. The femoral component is non-cemented. Tibial component is cemented in, meaning they use bone cement and make sure that it stays in place. You will have a drain, a pressure dressing, and that's placed to decrease the edema and bleeding. Again, check for neurovascular compromise, because we don't get Martin syndrome. Here you can see the cartilage is gone, and you've got, or very highly damaged, and they will put that replacement in. This component basically sits on the top, and this is the part that rotates. Okay? Mild redness at the incision after a knee replacement is normal, but severe redness may be a sign of infection. Postoperatively, we're going to start them with that CPM machine. You may see ice packs or other cold therapy used to decrease swelling. Remember, typical ice pack is 20 minutes on, 20 minutes off. Swelling and bruising are common. We want to maintain in a neutral position, but there's no restriction on side-to-side movement. Physical therapy is very, very important for these patients. Any questions about hips or knees? All right, let's quickly go over some of the cancer stuff. Because you just need to know at least some of the names of them. Bone cancer is bone cancer. It's just like any other type of cancer. This is the one that you're going to see most often in childhood, is an osteochondroma. These are benign. Typically, femur and the tibia are involved. Chondromas, usually you will see lesions of hyaline cartilage, often in the hand and feet. These are benign tumors, but they can cause damage to that bone and sometimes have to be surgically removed. Okay? These are the malignant ones. Osteosarcoma is the most common type. Remember, this is one of the tumors that I told you that can develop after using that 40O for more than 2 years for osteoporosis treatment. Commonly occurs in that 10 to 30 years of age, more males than females. Found in the distal femur, proximal tibia, and humerus. It causes pain and swelling. It does metastasize to the lungs within 2 years of treatment and often results in death. Typically, what you will see with treatment for this is amputation of the limb and chemotherapy to try to prevent that metastasis. Ewing sarcoma is the most malignant type of tumor. Very pain, low grade, leukocytosis, anemia. You may see it occurs in the pelvis and lower extremities. Age is 20, male to female. Not a good outcome, not a good prognosis for these patients. Okay? So what you will see with this is, I don't know if you can tell it on here, but this leg is much, much larger than this. And it's not because of muscle development, it's because of the tumor. Often what you will see, chondrosarcomas, these are cartilage tumors. Middle-aged and older adults, okay? Metastatic bone cancers are the ones that I see most often. Prostate, breast, kidney, thyroid, and lung. Usually you will see the sites are the vertebra, pelvis, femur, and ribs. Since I work neuro, what I usually see most often is vertebra. Okay? One of the things that you need to know is that you will develop pathological fractures from this bone net. And if they can treat this before those vertebrae collapse, we may be able to save bowel and bladder. But if they have lost function of bowel and bladder because of that fracture, then typically that person is going to be dependent on someone else for bowel and bladder function for the rest of their life. Okay? Bone pain from bone cancer is extremely painful. And these patients need to make sure that they've got appropriate pain medication, appropriate treatment for that pain. Now, with other things that you'll see, psychological support. Often they will do a needle biopsy for staging and treatment. Chemo and radiation. Sometimes it's done as treatment, like with the osteosarcoma, to prevent mets. Sometimes the radiation is done for palliative treatment, because a lot of these tumors are not that radiosensitive, and they are done for pain control. Okay? If they try to surgically repair, they may do limb salvage procedures, which is what this is. What they've done here is just basically taken out the bone around the surrounding area of cancer and replaced it with certain prosthesis. But a lot of times amputation is the treatment choice. Because unfortunately, what we're trying to do is to prevent those mets. Okay? Quick and dirty. But think about what Ms. Beaver talked to you about chemo. Okay? What do I have to worry about? It doesn't matter what kind of chemo it is. I have to worry about what with my patients? Infection. Because they get bone marrow suppression, their white blood cells are decreased in function. I'm going to worry about also low red blood cell levels, low platelet levels. Okay? I have to take precautions. They can't be around sick people because of their suppressed immune function. Okay? What about radiation? What do I worry about with that? depends on where it is. Skin burns, okay? You might see it's intensive treatment. Sometimes it's done as a palliative measure, so you might get radiation to an area for like 3 to 4 weeks in short periods of time. Skin burns or skin irritations can occur. Fatigue is common after radiation therapy. Okay? The other thing that you need to worry about is that sometimes people may not be able to get radiation therapy because they've already had radiation therapy at a couple of other sites. There is a lifetime limit. Though, if the person is dying anyway, what does it matter? But there is a lifetime limit. Okay? So, think about what your care is going to be, whether it's chemo, whether it's radiation. Doesn't matter where the cancer is. Your nursing care is, and what you're assessing for are going to be pretty much the same. Okay. I know I'm worn out with talking so much, and I know you're worn out with writing so much. So what I would suggest is make sure you get the tests, quizzes, okay, at some time in this weekend, whether you study all weekend, which I don't recommend. At least take one day for yourself. But I will post the answers to those quizzes, okay?